and welcome to the 23rd meeting of the Health and Sport Committee in 2019. We have received apologies from Miles Briggs and David Stewart, and also on behalf of Sandra White. Can I ask everyone in the room please to ensure that mobile phones are off or on silent, and while it is acceptable to use mobile devices for social media, please do not take photographs or record proceedings. The first item on our agenda is the third of our evidence sessions for the second phase of our primary care inquiry, and therefore pleased to welcome to the committee Ainsley Dryborough, who is the local area coordinator in the Fife Forum, the Fife Health and Social Care Partnership; Caroline Cherry, service manager, Adult Assessment and Partnership, Communities and People, clerk manager and Stirling Health and Social Care Partnership; Jerry Purr, director of integration with the Alliance; Dr. John Anderson, organisation lead for primary care with NHS Health Scotland; and Anne Crandalls, social prescribing community link worker, network manager with NHS Lothian. Welcome. I'm sure members of the panel will have followed some of the evidence previously given both in writing and in previous panels. They've stimulated interest in a number of areas which I know are within your experience and expertise. Can I perhaps ask witnesses to start off by simply, given the areas in which you yourselves work and some of the questions around definition that can be important here, what do you understand primary care to encompass in terms of health and care services, public health and infrastructure, and who do you believe is responsible for oversight and for the overall vision and purpose and drive of primary care? Who would like to start? Anne Crandalls?
In my sphere, because I can only really talk about my sphere, which is Edinburgh Health and Social Care Partnership, I work as part of the primary care support team underneath our strategic lead for primary care. So in my experience, that means general practice, pharmacy, link working, social prescribing, premises, looking at supporting the GPs and their primary care improvement plans. And for me, that responsibility goes up through the hierarchy of the primary care support team and Edinburgh Health and Social Care Partnership and on to the IJB. But that is probably the limit of my experience. It would be wrong to say anything else.
Okay. Who else would like to have a crack at the wider picture? Jerry Purr.
Thank you, Chair. I think primary care really for us is at the forefront of access to health and social care services. For us, the benefit of integration we see through primary care is in projects such as the Community Links Practitioners, which Anne has mentioned, and that's about linking the front door of health and social care into the wider aspects of both the third sector and other organisational support for individuals. So primary care, I think, is a gateway. It's a gateway into secondary and tertiary care, yes, but it's a gateway into the vast scope of both statutory and third sector and indeed independent sector services. So it's a vital part really in terms of that first step for many people. But in the past, I think it hasn't really had the support that it requires to support individuals accessing that service. But I think increasingly, particularly through examples such as Community Links Practitioners, we've seen that gateway is starting to open wider into the expanse of services that are available within the community, which is really the delivery of integration at a very practical level.
Sure. I wonder, John Anderson, given your role in Health Scotland and if you like, a government perspective, what is your sense or understanding of the scope of primary care?
I mean, I think there's a traditional view of the scope of primary care, which is probably expanding in recent years. I mean, the heart of primary care, I think, is still general practice, augmented by the full range of medical, nursing, dental, ophthalmic and AHP services and professionals, largely directly accessible to the public, with the exception, obviously, of A&E, for example, as direct access in secondary care. Increasingly, I think, reflecting contributions from colleagues, we need to consider primary care as including a wider range of community and third sector organisations, because increasingly we will have to look to them to improve the health and well-being of the population, which is not something I think that the traditional role of general practice and primary care, slightly wider, can be required to undertake on its own and probably not be successful if it tries. In terms of overarching governance, authority, running, it's a complex picture, ranging from Scottish Government authority through to HSCPs and IJBs. There are obviously the professional organisations such as the RCGP and the union stroke professional organisations such as the BMA. Also a big hand to play in this. So it's a very complex picture, and I think the take-home message from that is that collaboration and cooperation across these various governance authorities is probably critical if we're to make the kind of changes we need to modernise primary care.
Very much. Anyone else? Yes, Ainsley.
I work directly with the GP surgery, so I see that as the primary care. We take referrals from anybody within the GP surgery, so we have mental health triage nurses, district nurses, podiatrists and the nurses, and that's what my role is, to lessen their workload by taking on people that use non-medical needs for appointments.
Okay, thank you very much. Caroline.
Yeah, similar to the comments that Jerry made, I think I see quite a wide, access to local services. I'm very involved in third sector, working with local people. I'm also very involved in looking at the prevention of well-being. So I think it's much wider than just the kind of health professional role, which is maybe the traditional way of seeing it. So we are very much talking to local people about avoiding using their GP surgery at times. What's the best way to keep yourself well and healthy in the community? And I think that actually involves a very wide range of colleagues and partners.
Okay. Emma Harper.
Thank you, Convener. Good morning, everybody. Many areas across Scotland are delivering their primary care in rural areas, so I'm interested to hear if there are particular problems regarding organisation, planning and delivery of care in rural areas, and is this reflected in the allocation of resources and national guidance?
Who would like to respond to that? Again, perhaps Jerry Power.
Well, as a third sector intermediary organisation, we do cover all of Scotland. I think that in terms of our specific experience in primary care services, it's very much focused on, well, a couple of aspects, but primarily community links practitioners. And I think that the issue is about how the allocation of community links practitioners is delivered across Scotland, and whether or not the areas of deprivation are actually tackled on a equitable basis, both in urban and rural areas. For us, very much we're focused on the urban delivery of services within Glasgow. However, I understand from colleagues that there are issues in terms of how that allocation is made in a rural area. But for us specifically, I think that our experience has been in more urban areas rather than rural.
Okay. Anyone else? Anne Candles.
Just add that although we are very much urban focused as well, we have been to visit colleagues in NHS Highland to discuss community link working, the issues, the strategies, the planning that's required, and that's a piece of ongoing work.
Right. Excellent. Caroline Cherry. You don't need to.
Don't need to
worry
please.
about that, no.
Okay. Yeah, just wanted to pick up on some of the sort of opportunities and challenges of working in rural areas. So The pilot we've been working in rural South West has covered a fairly rural area, and I think in terms of looking at inequality, there clearly are transport issues, and it comes up time and time again. So local people will tell us that one of their major challenges is travelling to appointments and services, and I think we have to look at the digital opportunities to access, you know, online consultancies, because the reality is many older people cannot keep travelling. I think, again, within rural areas, the opportunities are that I think that rural communities tend to be more resilient. I think there is a kind of a sense of we're all in it together and we've all got to use what we've got. So I think they can be more imaginative, and they can use resources slightly differently.
Mm-hmm. Sure. Emma.
The point you bring up about digital is really important, because I know in the southwest of Scotland, in Wigtonshire, they're piloting Empower and CoSync, which are digital opportunities for, it's not face-to-face, but it's face-to-face using iPads and digital technology. So that's something, I'm assuming that would be one way of tackling rural issues, especially as you describe transport's a real challenge.
Caroline Cherry.
Yeah, I think the other thing we've been doing is trying to do some much better promotion of digital for particularly older people. I think we've got to get past this barrier that older people can't access digital, and that's just it. So we've been going out and doing presentations talking about basically how you can use your iPad, how you can make appointments, and trying to get that message across, that what you can do for yourself. And I think we need to do much more of that.
Anybody else on that one? Okay, look. Emma, do you want to move on?
Yes, thank you.
Yeah.
So I'm last week I asked questions about GP clusters and how they work, how they don't work, what could be done different. So I'm interested in how integration authorities and GP clusters are developing, and how can we support that work. So I'm interested to hear whether the National Health Service and Health and Social Care partnerships, as well as all the managers and the cluster leads, GP leads, and everybody in their respective roles, do they understand what we need to achieve as far as the primary care objectives and supporting optimal clinical outcomes?
Ainsley Driver.
I feel that I work in Fife and cover Cowdenbeath and Logelly area, and I work directly from the two surgeries being allocated, and I do feel that the overall view is the same, that we all want the best for the patients, and we want to help lessen people using appointments for non-medical reasons. So I do believe that everybody I work directly with does have that holistic approach.
Anne Crandles.
Although we don't work in GP clusters per se, we do work closely with the clusters wherever possible. For example, if we're recruiting a new community link worker, we will ask a local GP or the cluster quality lead to join that interview panel, so that there is real involvement from the GP practices. We do have one area in the southwest of Edinburgh, the Pentlands GP cluster, where we're doing an interesting test of change that sits aside from the National Programme of Link Workers. And we're doing this in partnership with industry, looking at elderly population, social isolation, with 6 practices there. And that is in a very early phase, but we're beginning to pick up referrals from that.
Jerry Power.
I was at a meeting with primary care colleagues 2 weeks ago, and certainly my experience is there is an incredible amount of enthusiasm for the investment in practices, particularly around community links practitioners, practice pharmacists, etc. One of the, just an anecdote, if you like, the way the funding for community links practitioners is allocated is on the basis of the highest area of priority working down through practices, which sometimes means in clusters some practices might get an allocation for a community links workers, whereas a neighbouring practice won't because they're slightly further down. The concern there, of course, is whether or not the allocation for community links practitioners, the 250, will actually ensure that all of those practices who would benefit from a community links practitioners will get that allocation. And you may find a situation within a GP cluster that where the majority of GP practices have a links practitioner or another bit of primary care investment, a neighbouring practice won't. And I think that's leading to some disparities within that cluster area. And that might be something that we need to address by seeing a bit more investment in those areas where the whole cluster requires that type of investment. That's just some feedback from primary care.
Sure. Anne Crandall.
I take the point that Jerry makes, but in Edinburgh we have looked at the primary care improvement plan and resource allocation based on practice population size and other factors in there, and have offered the practices opportunities to use some of that resource for link working, so that we would spread it from the national programme out to mainstream practices as well, if they so choose to have a link worker. So that's helping with a bit of the equity issue in Edinburgh.
John Anderson?
Thanks. I think the area of expertise or the area of understanding that we're able to speak to is related to the use of population health data in a public health context to address population health challenges and health inequalities at cluster level. There is a requirement for, I don't know what's happened here, there is a requirement for additional data, intelligence and information at cluster level to enable clusters and those working in and around them to understand what the local population health needs are. And the creation of Public Health Scotland in April next year, bringing together the skills and expertise of ISD and Health Protection Scotland and NHS Health Scotland, will offer a major opportunity to increase the local intelligence and data that we can provide to clusters to help them understand what the local priorities are, identify service gaps and make service improvements on that basis. I would echo colleagues' comments that there is a huge degree of enthusiasm and optimism in and around clusters for improvements, but they will need support from public health organisations such as New Public Health Scotland to take advantage of that enthusiasm. Yeah, I'll probably stop there.
Okay, no, I think that's it.
I'm interested to know what role the responsibility do the public have in engaging with primary care services and their understanding of this new language of GP clusters and things like that. You know, could more be done to engage the public or inform them, and again, what role does the public have to play in developing their own services?
Ainsley Dragra.
We, within Fife, have kind of broken it into 7 localities, and we regularly have locality meetings, and the public are invited along to these meetings to be included in the discussions on what's needed for that particular area. So each cluster runs different, or each locality, sorry, runs differently depending on the needs of each locality. So the public are involved in these meetings.
And do you get a high level of involvement? Does it vary a bit?
It depends on the locality,
yeah,
what involvement we get.
Caroline Cherry.
Yeah, not so much necessarily answering clusters, but the submission we gave talked about the role we've been having in working consistently with a local community for a considerable period of time. So that's been a group of older adults, third sector providers, links with GPs, health and social care. We've really called it a community reference group, and that group's helped, I think, to shape what they would like to see as their local priorities. So I think we'll have to move from a sort of more consultation model to really think about getting some local groups that are very, very involving of older adults or adults in general. The reason we set it up in that particular area is that those local people decided that older adults care was one of their top 3 priorities. So it fitted for us to say, well, let's see what we can do. And we've been doing a lot of work around self-management around befriending, loneliness and isolation. Again, trying to focus on the prevention parts that people can get more involved in, and I think it's worked well.
Jerry Power.
I mean, individuals and communities play a vast role in supporting themselves. And I would just mention two particular areas which are important in primary care. And one is House of Care, which is a model which has been delivered within GP practices, which is very much a partnership between the primary care team and the individual. So it's about understanding the whole assets-based approach, co-production. It's about understanding that the individual patient brings something to the relationship with the primary care professionals, and that working together they can understand and help each other about what the individual can do and what the practitioner can do. And that's been rolled out across Scotland. That's something that's very successful in those GP practices which take that forward. And the other thing is the use of ALICE, which is a local information system for Scotland, which is an open platform search engine which communities and individuals can actually describe what services are available within the communities, and that's available to the public and is also used by practices and by community links practitioners to identify what particular self-help and community support there is available. So there are tools out there and there are models out there which actually support the role of individuals taking more upon themselves to look after their health, and clearly I think that needs to be promoted on a bigger and wider basis to understand how people can help themselves.
Anne Crandall.
Thank you. Can I just add to that? I echo everything that Jerry's just said, and yes, we use databases here in Edinburgh as well, and that what matters to me, conversations with patients. But just to add to that and to strengthen what we do with the public in Edinburgh, next year we will be adding a commitment to the criteria for our third sector partners that they have patient focus groups within their premises that we can tap into and get direct feedback on the services that we are providing. So that's very much our intention going forward.
Thank you very much. John Anderson.
Just very briefly, to certainly agree with my colleagues and add that the evidence does show that closely involving patients in the planning and delivery of local services can help increase their personal power to influence service provision in line with local community needs. And these community-led approaches can enable primary care to be far more effective at the prevention of illness through empowering people to influence the development of services that enhance their health and their well-being across the wider community.
Just a wee quick sup. Caroline, you said that you had spent a considerable amount of time with people. What does that mean? Because my understanding is, I'm a former nurse, and I understand that health and social care is complicated, and we're trying to implement transformational change. So are we keeping up? Are we changing fast enough? Is everybody adapting well enough? Because if a considerable amount of time is needed to engage people, what else could be done to support faster change?
Yeah, I mean, I think the considerable length of time is because it was a pilot approach, and we needed to kind of test it out. I think there are models that we could look to try and pull, whether you call them patient forums or a local health and care group. I think if you just take that as a model to try and get people involved and just get people to come along and talk about their health and social care issues, what they'd like to see in the area, focus on prevention, self-management. So what it's involved is we've had a reference group meeting every 2 months for about 2 years. And we've got some good evaluations and feedback, but that's taken people a long time to understand. I think it's still health and social care, primary care, still quite complicated with a lot of changes that are going on. So I think it's bringing people on that journey, supporting them and genuinely trying to build relationships. We've also had, a bit like a community link worker, but we've piloted a resource worker, and he has been the key. Sometimes it's been able to talk to people more in depth and link people into the group. It's a very active local group, which is now I would say, much more empowered to think about what it is they want and need in their area.
Okay, thanks.
Thank you very much. Brian Whittle.
Thank you, Camilla. Good morning to the panel. If we could Move on to the primary care budget. I think a general question to start with. Do you think the primary care budget as part of the overall health budget is appropriate at the moment? Is it at the right level? Easy question.
John Anderson.
Thanks for that.
Hospital pass?
I would probably start off by saying that NHS Health Scotland, as an organisation which gathers high-level research and evidence to inform health decision-making, is probably not best placed to judge the precise funding allocation which, for example, general practice or primary care should receive as an overall budget. What I can tell you from general reading is that the RCGP and the BMA, for example, have both independently called for 11% of the healthcare budget to be made specifically available to general practice. And the rationale behind that is that general practice is involved in the delivery of proportionate universal care, in responding unconditionally to need which presents, with compassion, long-term relationships, trust building, and patient-focused outcomes, increasing the sustainability and capacity and capability of primary care to undertake the day job would, by logical extension, and this is certainly their arguments, increase primary care, specifically general practice's ability to address health inequalities and deliver population health challenges. Now, we don't have specific evidence in our organisation as to what exactly the figure should be, but as I say, the BMA and RCGP do have papers and some degree of evidence on this, and I think refer to European countries where there are some similar figures, I think, around that kind of percentage.
Okay. If anybody else wants to? Oh, everybody's dodged it. Well, I think if we take that further, then if we look at the allocation of a budget to primary healthcare, do we think the split between the various elements of primary healthcare is in proportion? blank looks. I mean, are we looking at, you know, well, we're obviously looking at primary care and community care services, looking at the third sector. Are we able to fund them in proportionately?
Jerry Power.
From the perspective of the third sector, there are a vast amount of resources out there. I think it's about understanding how they can be best supported. So I think that we're now open to it through integration. We're now open to involving the third sector more within the provision of health and social care. If you look at social care, for example, the majority of social care is provided through the independent and third sector anyway, so we need to recognise that these are key players in providing that. It is about ensuring at a local level that third sector organisations aren't simply seen as a default position for a lack of resources within primary care or health care or social care, but that the opportunities through the health and social care partnerships, through the IJBs, is to actually look at this as part of a collective of resources, not just the fact that the third sector sit to the side somewhat, but to actually see can they provide services which complement and possibly enhance the services that are provided through the statutory care. So it's about making best use of a resource that's already existing there, and understanding these are partners, not services which are really an adjunct. They should be integrated fully with the services that are provided by the statutory sector, and it's about recognising there should be some parity of funding for these organisations. But that requires a mindset that says that we should be funding third sector organisations for certain things, statutory for other, and that both organisations and both systems can complement each other, but that you have to fund them on a basis of parity. Who is best to actually provide those services?
I'm sorry I can't answer your bigger questions. However, I would like to reinforce the comments that Jerry's just made. We're very much aware of just how much pressure we are putting on third sector colleagues through social prescribing, admin, signposting and community link working. To the point that we want to keep on flagging that up, that this needs to be resourced if we are to continue to do this good piece of work, but we need to have the ability to refer with confidence and know that we are not burdening our third sector colleagues.
Brian?
If I'm making it, I want to just explore that a little bit further, because I think, you know, I have a very specific interest around what the third sector can deliver. Let's say, for example, in drug and alcohol, you know, specifically. So again, I'm going to ask this question. I think the third sector are at a capacity, and they're at a capacity because of the way in which they're funded. Now, the way we're looking at IGBs and funding, transforming the way in which we deliver healthcare services would suggest to me that there's an opportunity here to look at the way in which we fund the third sector and make better use of the way in which what the third sector can deliver. And again, I'm going to ask the question, I'm hearing that's what we want to do. Is that happening? And if it isn't happening, what needs to happen to leverage the great work that they are doing?
Anne Crandall.
I think we need to recognise the great work that we're doing and not take it for granted. So turning your question on its head, there are definite gaps in services, so gathering proper intelligence on those gaps and making sure there's an equity of service and a local need that is met. So there's a piece of mapping to be done before we think about the resourcing, so that the resourcing can then follow intelligently. So there's work to be done, initial exploring, before we get round to how do we do it. We need to know what we're doing.
Jerry Power.
There's some barriers there. Funding, for example, in terms of the longevity of it, the fact that for many third sector organisations, funding at the very best might be over 3 years. Often it's less than that, which means it's very difficult to plan services and to work in partnership. Procurement is another issue. So we hear, for example, that it's difficult for health and social care partnerships and IJBs to invite specialist organisations to come along and design services, because that might be seen to give them preferential treatment, and therefore they're excluded from the actual strategic planning of those services sometimes. So these are particular areas that are of difficulty as well. There's an issue of trust as well. Do you trust third sector organisations to provide services rather than statutory organisations? These are barriers that still need to be overcome. We took a piece, the Alliance undertook a piece of, we commissioned a piece of independent research recently. We need to talk about integration. How does it feel like for you? And this was independent research which actually asked statutory providers, not third sector providers, what some of those barriers were, and these were the things that were coming up. The fact that there are still some barriers around the commissioning process, about involving third sector organisations in actually the provision of services, lack of trust, fear from some statutory sector organisation that there's a risk there. So these are still areas that are actually preventing statutory and third sector organisations designing services which actually transfer those to some third sector organisations which may be better placed to actually provide these services. So that's still a concern. The paradigm in terms of how we provide services is shifting, but it still has some way to go.
Okay. John Anderson.
Just a very brief point, echoing again what my colleagues have said. From the general practice perspective, it's important to remember that GPs have a responsibility, and other members of the practice team too, who are referring to third sector and community resources, to ensure that patients are receiving the kind of support for as long as they need it, in the kind of quality way that they need it. Now, use of the third sector by general practice and primary care requires long-term relationship development. and it requires time for that trust to be built up, so that the referring practitioners understand that when they refer a patient to these services, the patient receives a good service and gets better, improves, and that gives the general practitioner the confidence to send other people to that service. I'm told by many people, and our organisation is often told, because we work extensively with community and third sector, that service stability and funding longevity are really critical issues underpinning the development of these long-term relationships and trust between referrers and providers. So it's a general, it doesn't tell you how much to spend on them, but it tells you that stability and funding are critical issues to look at.
If I could just push that a little bit further there. So, if two questions come out of that. Are we aware, fully aware of what's available in the third sector in this environment? And do we need to audit that? And secondly, in the terms of the trust element, is there should we be putting together a framework that third sector organisations should aspire to gain that level of trust? Is that the direction of travel we should be going in?
John Anderson.
Can I answer very briefly from my understanding, but of course my third and community sector colleagues will have far greater depth of knowledge in these areas. I'll leave the question of service level agreements and kind of formal written arrangements to them, but we are aware that, for example, the ALICE mechanism, a local information system for Scotland, does comprehensively map third sector resources and make these available via the web to whoever wants to access them. And typically we are now seeing in general practice the increasing role of community links workers and also other social prescribers in and around the practice making use of these resources. And of course a key aspect of the role of linked workers, for example, is to make sure that they know exactly what's available in their area, to build relationships with these providers and to keep basically a rolling catalogue, an up-to-date catalogue of what they can in fact refer patients to. So I think that possibly helps answer your first question. But
Jerry Power.
The recent ministerial strategy group looking at integration came out with a number of recommendations, and one was the fact that on the broader front, healthcare organisations needed to understand better what was available for third sector organisations and respect that a contribution that third sector organisations were made. So at ministerial level there is a recognition that more needs to be done around that. What we'd like to see, I think, is whilst there is a framework that has been issued to IJBs asking them to indicate how well they think they're doing in terms of engaging the third sector, we would like to see a bit more evidence about how that's working, some form of tool that is used, such as the public sector improvement framework that the improvement service use, to actually identify specifically how health providers, both from the health and social care partnership level right through to primary care, are actually engaging. So whilst tools like ALICE may be able to inform the process about what's available in the third sector, I think that there needs to be more done to understand what is available on a local level, because ALICE will give a snapshot of what's available because it's an open platform. People will put on what they want to put on. But it's really about understanding what services are available locally. So I don't think that there's a full picture of that. I think that there has been, that the Ministerial Strategy Group report helps to actually push that a bit further, but I think more work is needed to understand what's available.
And Anne Candles.
Thank you. Can I just pick up on some of those points too? So yes, we tend to use our third sector interfaces red book, but it's a similar idea to ALICE. So we know where the resources are in a database. It's the gaps that we're not so sure about in Edinburgh. Where are the missing fishing clubs or the lack of lunch clubs in another area? That's what we need to map. That's what I was really referring to before. We actually have a very good relationship with our third sector colleagues in Edinburgh because we work in partnership to deliver the link working service. So we are building trust with general practice round the city as more and more start to get involved in social prescribing in its widest sense. But I would agree what we're not so good at is having feedback from those activities that we refer people to. We know when we send them, we know how many we're sending along. We have anecdotal evidence that 60 to 70% of those people report tangible benefits, but we don't have anything concrete, and that is something again that we want to explore going forward.
Thank you very much. Alec Cole-Hamilton.
Thank you very much, Convener. Good morning to the panel. Thank you for coming to see us today. I'd like to talk about the complementary nature or lack thereof of the models of medical care and the social model of care. Can you tell us what you see or how you would define the social model of care?
That's a good general question again. Jerry Power.
I'll have an attempt.
By all means. Not everyone has to answer this question. Just start us off.
I think that health and social care are inextricably linked. I think that well-being of all of us, it really overlaps. So it's difficult to say that there should be a separate social model of care. The way I see it, and we keep coming back to community links practitioners, is that link, I think, is the element there, and it's about how do people present within primary care, and a lot of the issues they present within primary care are much more complex than a GP or a primary care practitioner can deal with in the limited amount of time they've got available. And what we see is that once they have an opportunity to actually look into that and engage on a longer basis, that many of those health issues are linked to social issues: housing, financial, relationship, weight management. So a lot of the causes of their health problems are actually social problems. So I think that the two are linked, as I said. And as far as the social model of care is concerned within primary care context, that the fact that we now have resources and we recognise that these determinants of health are actually important, that the investment we're making in those resources are incredibly valuable and are starting to address some of those social issues.
Caroline, Jerry.
Yeah, I totally agree, and I think that was, really, really well explained. I think, for me, just if you put the person at the centre, so everything to me should be person-centred rather than a model we're trying to fit people into. But also, I think the role of informal supports are absolutely crucial. So when you see the person at the centre and surrounding them is their community and their informal supports, I think that's where the community link workers have real connections. They're able to connect people not only to formal services but also to informal supports. But like Anne talking about fishing clubs, we spend a lot of time trying to focus on lunch clubs and tea and tunes, drop-ins. And they're not formal services, but they're things that keep people well. They're things that improve somebody's quality of life. So to me, it's very much a person-centred but community well-being model, and it's very hard to separate the social, the community, the quality of life and health. They're inextricably linked.
Anne Crandles.
For us in Edinburgh Health and Social Care Partnership, it is very much about driving down social isolation in whatever form we can do that, whether that's working with elderly and popping along to see them, or, as Caroline said, taking them to a social activity and getting them engaged and interacting with other members of the community. Social isolation is key in this.
Okay, thank you very much. Alex.
Thank you, Convener. Thank you for that. If we consider that every patient in Scotland, and ourselves included, are on a continuum of care, and that is bookended by two very sort of worthy philosophical points of view. So in the wellness end of the agenda, which most of us I hope are in, we're in the prevention side of things. We're keeping fit, we're eating well, we're sleeping as much as we need to. And at the far end of the spectrum is the realistic medicine agenda, where we're coming to end-of-life issues and choices that are being made. Now, I think every party in this Parliament has signed up to both agendas, but the application of those those agendas is perhaps not as good as it could be at a local level. How far are we from achieving success in both ends of this continuum? There's quite a lot there in one question.
That's another very large question.
So if we take prevention first, what could we be doing better? And then we'll come on to realistic medicine and end-of-life issues as well.
Yes, please, John Anderson.
You're right, it's a complex and large question. If I could just start with just saying a little bit about the role of prevention in primary care, or the role of primary care in prevention. It is worth re-emphasising, as I'm sure you all know, that health inequalities fundamentally arise from unequal distribution of power, wealth and resource across communities and populations. Now, these differences give rise to differential experiences of a wide range of social determinants of health, including education, housing, employment, income and access to services. And it's these differential experiences that underpin differences in population and individual health and give rise to health inequalities. Now, primary care's ability to reduce health inequalities lies mainly at the mitigation end of the spectrum, is therefore limited, but it does have a role to play in primary prevention, and that's primarily through action on the social determinants of health. And we've heard examples here about referral through links workers and social prescribing to a full range of community and third sector services. And it is worthwhile bearing in mind that health and well-being are two sides of the same coin. If you dent your well-being, you will dent your health in the longer term. And improving people's social inclusion and involvement in society and personal resilience and all the other social determinants of health that we have will have an impact on their health in the longer term. The evidence is really quite clear on that. And one example of how you can undertake that effectively in general practice is through routine social inquiry as part of longer consultations. Now, I wouldn't necessarily think that my own view is that realistic medicine and maintaining people's health and well-being through community involvement and other things aren't so much opposite ends of the spectrum as they both cover the spectrum. And they cover the spectrum because of the principle of proportionate universalism, which is that every patient should receive the care they need in proportion to their need. So those patients that require more help and support, either medical support or community support, should receive more. Those that require a little bit less should perhaps not receive as much. Where realistic medicine comes into play is helping to judge those decisions as to when patients need more or when perhaps they need just a little bit less, particularly a little bit less in terms of medicalisation and potentially unnecessary investigations, etc. So realistic medicine is actually quite a complex topic, as you know, and I would certainly not profess to be an expert in it, though having read the papers and background, it does look like something we'll have to engage in. I'll probably stop there rather than going a wee bit too long. But.
Okay, no, that's certainly helpful. David Torrance.
Thank you, Convener. Good morning, panel. How do you plan locally for workforce requirement?
Anne Crandles.
From a community link worker perspective, we have come up with a rubric that, for example, for every 1,000 patients who are living in areas of concentrated economic disadvantage on a GP practices list, we will allocate 1 day of link worker activity. And we've been using that rule of thumb for 3, perhaps 4 years. It feels about right. We've nothing scientific behind it, but that's what we've applied, and we've kept on applying it. We've recently started to work, as I said earlier, with an elderly population, and we have nothing scientific to base that on, so we've just used our previous experience and thought this might all take a bit longer, so we'll have that and we'll see. So pragmatic, not scientific, but you need to start somewhere.
Jerry Power.
The only thing I can say about workforce, and we have seen this, although it is patchy across Scotland, is the fact that the workforce doesn't simply include the statutory sector. It includes the spectrum of of organisations from the third sector, the independent sector, as well as the statutory organisations. And I think in terms of actually planning workforce, there needs to be a realisation that the workforce is actually larger than simply what's available within the statutory sector. So the need to actually, one, involve those other sectors within planning is essential, and we have seen that is happening in various places, not all though. But also the fact is that you need to take a decision about who is the best, or which sector or which practitioner is best to actually focus on delivering the services. So you have to be open to that as well. It's not simply about saying that we have to continue to provide services through statutory organisations. And that's difficult for a variety of reasons. There are vested interests, there are risks involved, but I think that there's a need to actually see that, you know, that the workforce out there goes beyond the boundaries of the NHS and local authorities.
David?
Thank you for these answers. What is required nationally for you to recruit the required staff? And if the staff is there, is the budget there to recruit them?
That's a good question. Who would...
So not Mr. Thomas. I don't know whether the required budget is there to employ all of the staff that are required. Beyond me.
No, nobody else?
John Anderson, I think a national overview might be one for you.
Okay, thanks. I would just hark back to your previous question, just to say very briefly that one way to decide on the workforce requirements of an area is to understand the population needs in that area. And Public Health Scotland, from its inception in April next year, will be better placed to support a wide range of data and informatics that allow us to better understand the needs of populations and potentially use that to feed into national workforce plans, etc. I'm at risk of having forgotten your original question here.
How do we plan nationally for shortages in workforce? Like, and I'll give you an example,
Yes.
like home carers. And I know in the area I'm in, there's a huge shortage even in the private sector. So how do we encourage people into it, and how do we plan for it?
The example I know best, to be honest, is related to general practice recruitment and retention. But I think some of the principles of that will be that it will be similar across many of the professions. My own view on this, backed up to an extent by the evidence, is that general practice is in many respects very like every other job. It has to look like a good job to people that want to come into it. It has to be spoken well of in communities. It has to be properly paid and properly trained and properly respected. It has to offer good career progression. It has to offer interesting work and a good atmosphere, and it has to be, physical and IT infrastructure has to be supportive. And I think these general parameters apply to every role, including, for example, home care staff. There will be, I think, specific challenges in some of the lower paid jobs, but I would probably stop there and say that, not being a particular area of expertise of mine, it'd probably not wise for me to carry on.
Caroline Cherry.
Yeah, I'm involved in commissioning independent providers to provide care at home services and an internal care at home service. There's a lot of pressure on recruitment. What you don't want locally is a competition, because actually there really aren't enough people. And I think it's quite a complicated issue, the particular issue of home carers or care at home workers. But for me, echoing those comments, it has to be an attractive career. There has to be training prospects. There has to be flexible to your own sort of work-life balance. And I think we need to really value the role of frontline carers and really do much more locally and nationally to demonstrate the absolute fundamental role that they play, because without them, a lot of our older adults or adults at home would not be living at home. And it's the primary objective of health and social care, for me anyway, to support people to live well at home longer, and care at home plays a fundamental part in that. So it may not have answered your question, it's quite complicated, but I think it's a real challenge for us.
Thank you very much. Ainsley Drowborough.
I think it has to go back to what Brian said about the third sector and the fact that the uncertainty of the third sector that pick up the shortfall in the contracts and the short-termness that people are not willing to move into the third sector for that unknown future plans.
Okay. Okay.
How is information being shared amongst our organisations to help lead and require the multidisciplinary that you need out there in the primary care? How is that information being shared to get there?
Anne Crandalls.
Through data sharing agreements in the first instance. So it's a rough bit of context. Our link workers are host employed by local third sector organisations. They are not employed directly by Edinburgh Health and Social Care Partnership. So therefore we need to have data sharing agreements between the practices and all the local third sector organisations to set up nhs.net email addresses so that the information that is shared is secure at all times. So that needs good working relationships between the Health and Social Care Partnership, IT security, the Caldecott Guardian, and the general managers in each of those organisations, and continuous training for our link workers on, for example, GDPR, to ensure the security of that across the piece.
Thank you. Jennifer.
From a very practical perspective, links workers have access to GP systems, EMIS, etc., and will record their engagement with clients and patients on the same system as the GP. So there is a sharing of information at a practice level between those individuals. Whether or not there is sharing of information between organisations within the statutory sector, between the statutory sector and indeed with the third sector, I think that is again patchy. I think that there are concerns about risk and about how much information you can share between individuals. So in some ways it would be nice to have that joined up information for a particular individual, but one has to also be aware of the risks that are associated with that. Some of that is completely relevant. Some of it I think is maybe a concern about who you're sharing that information with, what the nature of a third sector organisation might be. But that's been something that's been, in my experience of 40 years within healthcare, has always been a problem about who do you share the information with? Can you share it with another department, with another organisation? And I think that we still have a risk associated with sharing that information, particularly between statutory, third and independent sector organisations.
Okay, thank you very much. Emma Harper.
Thank you. Just to widen a wee bit about community links worker, it's a new role, and the purpose is to look at embedding community link workers into GP practices, especially in areas of higher deprivation or poverty, to look at then signposting people to, I guess, non-GP, non-clinical. So I know that there's plans to have 250 community link workers across Scotland, and I think I looked at info that showed that we have at least 56 right now in post, but I'm just wondering if you can provide an update on how many community link workers we have across Scotland, and are the roles different in different localities?
Anne Crandalls.
Thank you. I can't speak nationally, but I can speak for Edinburgh. So as part of the national programme, we have a head count of 14 community link workers, which was our government allocation back in 2017. That is 13.2 whole-time equivalents, but we shave a bit off of that 0.4 for 2 people to create team lead roles, so there's operational leads out there in the community as well. And we're fortunate enough to have a bit of resource, a 0.6 and a 0.4 from third sector organisation colleagues as well. And then on our tests of change that I've referred to earlier, we have 5.4 whole-time equivalent link workers covering 12 practices in Edinburgh. So in total, we have almost 20 link workers, and we cover Almost 50% of the practices in Edinburgh at the moment, but I'll allow other colleagues to talk about their allocation too.
Terry Power.
We're a provider organisation for community links practitioners. We've just appointed another 10. So we're looking towards the end of this month of having over 30 full-time community links practitioners. I also know that the Health and Social Care Partnership have awarded other clusters, GP clusters, to Add Action, another provider organisation within Glasgow. So there will be shortly 40 community links practitioners within the Glasgow area. The models do differ across the country. Certainly the model that we operate, we have a dedicated full-time community links practitioner for each of those practices. They are paid for by the Health and Social Care Partnership. We contract with them, as do Add Action, for to provide those, and we have an honorary contract within the GP practices. I did say earlier that although there will be 40, there are significantly more areas within Glasgow that are considered deep end and high areas of high deprivation. It is certainly not my information that there is sufficient resources to appoint community links practitioners to all of those practices at the moment. I'm not quite sure how the 250 are going to be allocated, but certainly within Glasgow I think that we could see almost a doubling of that 40 if we are to actually ensure that all of the practices which are in areas of high deprivation are actually covered. But we're moving a significant way towards that. And as I say, models differ. Certain models for community links practitioners share community links practitioners between practices, etc. That is not the model we have in Glasgow. We feel that it's essential we have a full-time individual, and that seems to be working. They're certainly kept busy.
Thank you very much. Ainsley Driver.
As a local area coordinator, along with Anne and Jerry, it's a similar role to a link worker or social prescriber, but that's what we call ourselves in Fife. There's 3 local area coordinators being employed by Fife Forum to cover just the GP surgeries. And between us, we cover 9 surgeries within the Fife area. The localities that were allocated to us were for the more deprived areas. A similar model to yourselves, but as a local area coordinator, we're able to take the clients along to a community group that we've allocated that will meet their needs for the first couple of times to alleviate that nervous anxiety of going into something for the first time. And we are all full-time workers within the GP clusters.
Excellent. Thank you very much. Emma.
How is the referrals made? Are the community link workers the first professionals engaged with, or is it GP receptionists and then they say let's divert and signpost to a community link worker, or how are we deciding whether people go to a GP or a community link worker who then will signpost?
Ainsley first.
I can only speak for myself in Fife, but we take the referrals from anybody that works within the GP surgery. So that may be a district nurse, a podiatrist, a mental health triage nurse, or the GP themselves, depending on how they've presented in the surgery on that day for that appointment. It might be deemed that it was a non-medical appointment, and in that discussion they'll refer to myself, and then I'll meet with the client and we'll have a good conversation to find out kind of what's going on and what their needs are.
I think from the nods around the table, it's the same model elsewhere. Yeah. Caroline, did you want to add something?
Yeah, we've got a slightly different. Telling you about our piloting of neighbourhood care, as we called it. So we have a resource worker, as we've called him, and one of the things he has been doing is doing kind of health and social care drop-in sessions. So we've been doing drop-in sessions at all the GP surgeries, and so we're encouraging kind of local access, and it might not be referrals, but it might be questions about health and social care. So we're finding that, for example, we might get quite a few carers coming in and asking questions about local services, and I think again that's something that I'd be keen to promote.
Okay, so slightly different model.
Yeah.
John Anderson.
Could I just take a brief opportunity to mention that NHS Health Scotland has just completed a qualitative evaluation of the initial rollout of the of links workers to the 50 or so early adopter practices. That's currently in draft and should be available fairly shortly. It will include learning about the various models in use and critical success factors that are vital for effective rollout.
Thank you very much. George Adam.
Thank you, Convener. Good morning. Obviously, in our communities, there's challenges with people. We've all got mental health issues, but there's people that are struggling with mental health in our communities now. One of the questions I was wanting to ask initially is mental health. Should it be viewed primarily as a medical issue and required a quick response right away, or is there other ways we could actually work with it within our community? Examples I would give: we have in some parts of the country men's sheds where men go along there. They've been isolated, their partner's died, they're on their own. It's leading to potential mental health issues, but if you intervene at that stage and get involved in that type of group, it makes a difference. So that probably leads on to what role would the third sector have in this as well?
Who would like to address that? Anne Crantles.
Thank you. Yes, I completely acknowledge the issues around mental health, bearing in mind that the link workers are social practitioners. The highest level of referral to them are people with mental health issues, and we find that our role there is to get them involved in activities, to get them to engage, again, that social isolation, whilst they wait or are receiving mental health services as well. We occasionally find, but I don't have any statistics to back this up today, that once that appointment comes through, if they're well enough engaged in the community, they no longer require that appointment. But that's not the norm. But that's where we find most of our referrals come from, our mental health, people with mental health issues. So yes, we can help with men's sheds and many other things too.
Okay. George?
With regards to that, how do we get the third sector? The reason I mentioned men's shed in particular was because the male psyche is such of a certain age that if your doctor says to you, you've got a mental health issue, you're likely at a certain age, a certain time in your life to say, what does he or she know? You know, I'm not doing that. Whereas the third sector is more likely, if I use examples like St Mirren Football Club in Paisley, my constituency, will do work in this kind of fact because they're St Mirren Football Club, a 142-year-old institution, and people trust them. Well, that's right or not, every Saturday that I go, I'm not too sure. But they trust the organisation and they access it that way. So what I'm trying to kind of get down to is, you know, how do we get to that stage to address these individuals and manage to get the third sector at the front effectively? And, you know, if I use the St Mirren example, it's a perfect example. You've talked earlier on about funding. You know, it goes from year to year, but because it's a 142-year-old institution, people believe it's an ongoing thing and will continue. So how do we get to that stage that we deliver, we access that, and we deal with people in a way that they're comfortable with, as opposed to saying, here is the medical model that you should be going down?
Jerry Power.
I'm not a mental health professional. I think there's a combination of factors. Sometimes it is appropriate, entirely appropriate, that a medical model or a health model is followed. But just to echo what Anna said, a significant number of referrals that come through our community links practitioners are for areas which I suppose you could associate with mental health. There are big issues of social isolation, which can lead to mental health problems. And you're absolutely right. Some of the resolution to that is about helping those individuals engage more in community activities. I mentioned about the GP and primary care being a portal. It's about funneling out. The community links practitioner is just one step in opening up opportunities for individuals to actually engage in those community activities. And it's about having that dialogue with an individual, because it may well be that men's sheds is right for one person. Personally, it's not for me. Maybe I prefer to follow the football example. But, you know, for certain individuals, it's about trying to understand, build a relationship with them to understand how they can help. And colleagues have said that, you know, community links practitioners, it's not simply about signposting, it's not simply about writing down, go to this organisation. It's about accompanying them. It's about building that relationship. It's about developing walking groups or taking them along to fishing or going with them to football or to men's sheds, because a lot of the time individuals don't want to make that first step themselves. So the community links practitioner it's that link again. It's linking from that first presentation, which might come through a GP, into a vast array of resources that are available. But it's about spending time with a single individual to understand what's going to help them. And it could be men's sheds, it could be a vast range of other activities. It may simply that they want to actually meet once a week to talk, have a coffee. And the community links practitioners will do all of that. They will signpost, but they will also work with an individual. They will identify, they will accompany them to men's sheds, make sure that they're comfortable in that setting before actually, you know, stepping back and letting them engage in that. So it's about accompanying them on that journey. And that's how, if you like, the third sector is there, but it's about helping an individual to engage with what's available, not simply leaving it to their own devices to do. And I think that's how how the third sector actually can support an individual, but how the links practitioners help that transition.
Okay. Thank you very much. Thanks very fine. And we've heard a little about quality evaluation and monitoring, but I wonder, Brian Whittle, a last line of questioning on that.
Thank you, Convener. As you'll know, there is a national monitoring and evaluation strategy for primary care, so to allow us to evaluate primary care over the next 10 years. I wonder if I could ask just simply how the partnerships are implementing that strategy.
Anne Crandles.
I'm sorry, I don't have the answer to that.
Okay.
John Anderson.
Thank you. My colleagues in NHS Health Scotland have been intimately involved with many other organisations in developing the 10-year monitoring and evaluation strategy. It's worth remembering that that is an overall strategic approach to establishing the effectiveness of the changes that we're making. But that has not yet been operationalised, I think is the technical term, into what you would call a practical evaluation plan that has yet in large part taken off. What that involves is setting specific evaluation goals, understanding the best data and intelligence and approaches to evaluation that can be deployed in pursuit of understanding what exactly it is you're trying to show, and then collecting that data, analysing it and presenting it. I think that's the point at which reflecting the strategy's expressed desire to involve local systems in the evaluation, which is critical. That's the point at which I think local systems like HSCPs will be intimately involved in establishing what the evaluation priorities are, establishing what the data sources are, and taking part in the evaluation to show change across a very wide variety of changes that are taking place in primary care. So early days, I think, is the summary.
Right.
I think following on from that, I wonder whether all the relevant stakeholders are aware of this strategy then and will use it as a sort of direct to help in the direct evaluation efforts. And I think supplementary to that, I'm quite interested to see who you think should be responsible for the evaluation and monitoring of the services.
That's quite a good question. I understand that there is, for example, a comprehensive outcomes framework which has been developed to guide local and national evaluation. And I know that has been fairly widely publicised across the system with, for example, our partner organisations and across our public health network. The extent to which that has penetrated local HSCPs and IGBs, I am not particularly cited on, although I recognise that in due course that will be absolutely critical. Your second point was, I'm waffling on there.
Who should be responsible?
Yeah. I believe there's ultimately the owners of this evaluation strategy are the Scottish Government. But my understanding is that there is a kind of joint responsibility for the delivery of this evaluation across all partners involved in it. And that, as I mentioned earlier, that really must include local systems, right down to clusters, for example, which are implementing new models of primary care transformation. Because they are the people best placed to understand what they're trying to achieve, best placed to guide the evaluation, and best placed to help us gather the data that will tell us whether or not these models are worth rolling out nationally, or worth putting additional funding to, or worth adopting on a national perspective, on a national basis. So, yeah, a long answer to a short question, I'm afraid.
Thank you very much. I think that question of evaluation is clearly one to which we will return in due course. But can I thank all of the witnesses on this panel for their very helpful replies and information. And if there are any thoughts that occur to you after you have left the room, please feel free to drop us a line accordingly. Thank you very much. We'll suspend briefly for 2 minutes to allow the panels to change places. Thank you. resume, and can I remind everyone again to make sure that mobile phones are off or on silent, and not please to take photographs or record proceedings. For our second panel this morning, can I welcome Claire Stevens, Chief Executive of Voluntary Health Scotland, Susan Paxton, Head of Programmes with Scottish Community Development Centre, Gail Anderson, Chief Executive of Voluntary Action Orkney, Suzanne Martin, Senior Public Affairs Officer with Scottish Association for Mental Health, SAMH, and Jane Cumming, Director of Service and Innovation with Penumbra. Can I start, as I started the previous panel, simply by asking a general question, given the interfaces and interconnections that there are here and how your organisations are affected by those. What is your understanding of the scope of primary care in terms of health and care services, public health, and the necessary infrastructure to support that? Suzanne Martin.
Hi. I would say that, I agree with a lot of what the previous panel said. I think primary care is the gateway or the front door to health and social care support for the general population. That is not just sort of GP surgeries, although that is sort of the traditional view of primary care. The third sector has a role to play in primary care, along with other health professionals, allied health professionals, GPs, in terms of providing support services for the population, identifying health needs and health inequalities within the population, and addressing those. So yeah, it's the front door, it's the gateway. It also plays a preventative role, and I think the third sector and the voluntary sector have a large role to play within that. So that would be our view of primary care.
Okay, thank you very much. Anybody else on that wider question? If one of the things that, because we're looking at primary care as a whole, clearly we're looking at who else is looking at it as a whole, and the Scottish Government have laid out a vision, and there are other potential ways of looking at it. Is there anyone else in terms of overview or oversight of primary care that you would identify? Claire Stevens.
I think the exciting thing really about public health reform just now is that it opens up the way for the third sector to be more involved and to be seen more of a partner. Voluntary Health Scotland is a national intermediary and network for health charities and other voluntary organisations involved in health. And most of our members have a very strong focus on trying to address health inequalities. And if I think back over the last few years, historically, one of the frustrations amongst voluntary health organisations has been their knowledge that they are an asset and a resource for primary care, but their difficulty in, if you like, battering down the doors of primary care to be recognised, acknowledged and involved. And I think that's beginning to change, because I think there's a shift in understanding as to what primary care is, that it is as more of a collaborative and partnership endeavour. It is a gateway and a conduit to secondary and tertiary care, but also to so much more within the community that helps keep people well and healthy.
Thank you very much. Jane Cumming.
I was just going to add that while primary care is a gateway, it's often not the first port of call for people, that when people are starting, and I'm talking specifically about mental health, which is mainly my area of expertise, which is obviously there where I focus my perspective, that often people have sought more informal means of support, so that they're arriving at primary care at a point where they've identified clearly that there's an issue. So it is a gateway for people to access other services, to receive care and support immediately, treatment, assessment, whatever it may be at that particular point, but often maybe not in the way that we would like, or in the whole range of resource allocation in terms of what's available, but people have maybe sought earlier intervention, prevention, before they get to that point. So I think there is a wider and perhaps more informal area around primary care that should be considered as part of the overall, if that makes sense.
Yes, indeed it does. Thank you very much. Emma Harper.
Thank you. I'm interested in the particular challenges or problems in organising primary care in rural Scotland. We heard from the previous panel, when you mention rural, people immediately go north of the Central Belt, but there's actually a big rural region called South Scotland. and I'm interested in how we deal with the challenges of primary care and the changes required for our rural areas.
Feel free to address north or south.
And both would be good.
And both. Gail Anderson.
Thank you, Chair. Yes, with an island grouping, the challenges are quite significant in terms of delivery across, in particular, 13 non-linked isles who are dependent on ferry and air travel. That means that for a practitioner, whether that's third sector or statutory sector practitioners, it could be a whole day, it could be an overnight for a 2-hour session. Within small teams that are obviously within our small area, there are very small teams, and to take one person out for a day, day and a half, it has quite significant repercussions on the rest of the team. So the challenges there are quite significant in terms of access to services. Apart from GPs perhaps travelling, or some islands have GPs resident and nurse practitioners, but all other services are based on our main island, the mainland as we call it. So access to those services from the Isles are particularly challenging. I think also if we're looking at technological solutions, which would be absolutely appropriate given the barriers of access, we don't have the infrastructure, and those islands which would benefit most are least likely to be able to access technological solutions. So small teams, small staff teams, the challenge of delivering, transport issues and technological IT infrastructure are all quite significant barriers to making this work. I think, though, we can't underestimate the commitment of the communities in doing things for themselves. It's already been well rehearsed, the third sector, the significance of the third sector in contributing to community-led services, and that is happening. So some of these communities are very committed to sustaining their very small populations, to working with third sector, working with statutory colleagues to ensure that services are delivered as best they can be.
Okay. Suzanne Martin.
Yeah, I would agree that with a lot of what Gail has said, and I just want to make a point with regards to IT. While I think that is something that will, and technology in general, will help to address a lot of the access issues faced in rural communities. For people with mental health problems, it certainly shouldn't be a default. People should have the option of what kind of service they receive, and giving people choice of what kind of service they receive is crucial. We know that when people have more choice over what their support looks like, they're much more likely to benefit from that support, and that goes from everything to what type of care and treatment they receive, how they receive it, where they receive it, what time they receive it at. They're much more likely to benefit from that support if they have more choice over that support. So I would just caution that it shouldn't necessarily be the default for rural communities, and they shouldn't miss out on receiving supports that they would benefit from simply because of where they're located, which I'm sure a lot of the third sector organisations working rurally and a lot of the primary care health professionals working rurally are aware of and are looking to address.
Okay. Jane Collins.
So I would just add to the comments of my colleagues that all of those factors should have an influence on how services are therefore funded and commissioned, and procurement practice around. I heard the previous speaker talk about one full-time GP in a practice in the city of Glasgow, and often in rural areas then that's spread across GP practices, or if we're providing care and support to people in a rural area, it costs more. Because of the sort of simple things like the travel costs, between visiting people, but that's not often recognised in terms of the way that services are purchased, and I think a one-size-fits-all doesn't work, and so we need to factor all the things that people have mentioned into the way that we plan services in rural communities, so that we can meet the choice that my colleagues are speaking about.
Susan Paxton.
Yeah, I just wanted to build on what Gail was saying, I suppose, about the role of communities themselves in improving services and overcoming the challenges that affect particularly rural communities.
One of the areas of work that we're involved in is community-led action planning, so supporting communities to identify their own priorities that affect their health or their quality of life, and to identify actions that they can take to address that, which will often involve collaboration with service deliverers in that area. What we've noticed is that communities themselves are identifying the availability and accessibility of health and care services as an issue that they want to address. And for me, that indicates, I suppose, there is a willingness there for people within communities, and the organisations that, I suppose, tackle the issues facing communities have an appetite and a willingness to engage with primary care service delivery in order to improve the kind of services and the kind of particular challenges that they face. So I think what we need to be thinking about is what mechanisms would bring the two together. Because the concern may be that in communities identifying issues of importance to them may not coincide with the priorities identified by service providers themselves, or indeed it could just be a case that there is no process or mechanism there to bring those two together. So we'll be looking for service providers of any nature to be responding to the issues identified by communities themselves, and I think that includes primary care services, particularly the accessibility of them.
Emma.
Okay, thank you. I'll move on to talk about integration authorities and GP clusters and collaborative engagement that's required there. And I'm interested if you are, do you think that the right collaborative approaches are being made, or should we be looking at other structures to look at collaboration between GP practices and health and social care partnerships?
I'd like to comment on that. Jane Cumming.
I think integration, I think there are clear benefits to integration and streamlining processes and sharing resources. I think as was pointed out earlier, the third sector, independent sector, I think are the biggest provider of social care services, are often not part of the conversation in relation to integration. And so I think that's something that could be further addressed in terms of the overall collaboration. But to build on what my colleague was saying about involving communities and localities in establishing the priorities in their areas and using, I think that in terms of collaboration, giving community ownership to primary care in terms of health services, that involvement and participation that we look for becomes more meaningful if people feel that it then produces results and they can see the results of the forums or the collaborations or, you know, whatever structures we build. It's about, does that then influence what actually happens, you know, and provided we have that voice coming through, but it is actually does have the power and control to generate results for that community, I think is the critical thing.
Suzanne Martin, then Gail Anderson.
Thank you. I would say that in terms of sort of collaborative approaches and GP cluster working in particular, obviously I think my understanding is that GP clusters were introduced as sort of a quality improvement mechanism, and I wouldn't be best placed to comment on the efficacy of GP cluster working, but in terms of collaborative approaches with people who use services, I would agree with a lot of what Jane said, in that it's really important to listen to communities, and what Susan said, really important to listen to communities and what they would like to see within their community in terms of services. We did some research for our Scottish Government consultation on clinical governance that showed that the majority of people had never been asked what kind of mental health services they would like to see within their community. That's problematic if you're trying to provide community-based services for people with mental health problems, if you're not speaking to those people about what they need and what they would like from the service. In terms of our local services, we see really good engagement from people when we work with them individually on what they need. So I think talking to communities and talking to people in order to design services appropriately is really important. I was really pleased to hear from the previous panel about some of the work that's going on in sort of localities, holding meetings that the public can come along to and reference groups that the public participate in. I think that all sounds fantastic, and I hope that some best practice in terms of working collaboratively with the public and with local communities is being rolled out. I think that's really important.
Gail Anderson.
Yes, that collaborative approach is really essential, particularly in our own area with the small populations that I mentioned earlier. And a piece of work that we've done as the local third sector interface is to liaise with initially 7 island communities who were concerned about the level of service they were receiving for the reasons that we explained earlier. As a result of that, we commissioned some research just to identify exactly what the issues were for those communities, but also to focus on the assets that they would bring to any work that we could take forward. That piece of research resulted in 2 recommendations, one of which was to pursue with our colleagues in the Integration Joint Board, Orkney Health and Care, much more collaborative and co-productive pieces of work. That work is ongoing, and I have to say that there is real willingness to involve the third sector in this work in Orkney. The other recommendation was to work with communities to look at that lower level of well-being, what could be done within communities to support people to increase their well-being, their sense of involvement in their communities, which would lead to less drain or pull on more statutory services, more medical services. That piece of work, we managed as the TSI to get funding for that. We have established a project manager. We've established with 5 island development trusts what we call community wellbeing coordinators. Their remit was to build on the previous piece of research, to update that, to consult with their communities to see what exactly we could do collaboratively to provide the services that those islands needed. Now, a lot of that is dependent on the ability of third sector services to deliver in the islands, and also for the islands to deliver collaborative work. An example of that is in the island of Hoy, where the wellbeing coordinator has liaised with the GP very closely, and they have set up a unit that will allow people on the island to access support aids. There is obviously a facility on the main island, but for the reasons again stated earlier, that's really difficult for people to access. So we now have that on one of the islands with the support of the GP. People can come along, they can find out what's available to them, they can take away or try out some of the smaller pieces of equipment. And we're also liaising, that unit is also liaising with Sailborough, which is the mainland unit, to be able to provide and make appointments for people who need slightly more support. So there's liaison and collaboration between the island, between the GP and between that provider of aids. And that's only one example from this project of what can happen with a collaborative support between statutory and community and third sector.
Much. Claire Stevens.
The Audit Scotland report that reviewed health and social care integration last year showed that integration is still very much work in progress, and I think that's what all of the organisations in our network would certainly say. So in some areas, third sector and communities and unpaid carers and so on seem to be very well involved in planning and decision making. In other areas, it's less so. And I think one of the issues we raised in our written submission to you was that for third sector organisations wanting to be involved and with resources and assets to bring to the table, the levels of planning and structures and boundaries is increasingly complicated. So GP clusters now, but also localities, community planning partnerships, health and social care partnerships and so on. So it's quite a complex landscape for not just small voluntary health organisations, but also national health charities who don't necessarily have huge amounts of sort of resource on the ground at local level. So I suppose that's one point to make. In relation to GP clusters, interestingly, our members don't talk to us about GP clusters other than over in Drumchapel and Yoker, where the mental health community-based charity Cope Scotland has been working very successfully with its GP cluster there, which is led by Dr. Peter Corsten, so one of the deep end GP clusters. And they developed a piece of work called the Jigsaw Project, which was focused on quality improvement within the community of Drumchapel and Yoker for people with enduring and recurring mental health issues who it was recognised were falling through the gaps in services, not accessing necessarily the services that might be there for them. So that's been a really interesting piece of work, and I commend the report that's come out of that to yourselves, because it shows you how collaboration really can work at that local level between third sector but also the community partners. So people themselves are very much involved in that project, as is NHS Greater Glasgow and Clyde and other partners. So I think I have no information as to whether that sort of work at a cluster level is taking place in other communities across Scotland with that level of collaboration, including with the third sector. But certainly that's an example that is worth looking at.
Okay, thank you very much.
Just a final question is then we talk about co-production, which is a new word for people. We talk about collaboration and having multidisciplinary teams all work together, and housing needs to be part of that as well. But when we talk about this co-production, what role do the public have in developing changes to primary care? Do they have a responsibility? Should they have more of a voice? And then how do we then engage the public so that they know they're part of this co-production model?
Susan Paxton.
So at the SCDC we host the Scottish Co-Production Network and have done for the past 8 years. I do agree that a lot of people still see it as a jargonistic professional term. It doesn't necessarily mean that much to them, and I think even more so for communities and local people. However, I think simply put, it's just a way of working that recognises that local people and people with experience of particular issues have strengths and talents and can help contribute towards developing solutions to address some of the issues that they experience. And I should say that should be recognised of equal importance alongside professional perspectives and understandings. So for us, I think co-production is something to work towards. And we do experience a range of interest from across sectors and at different levels of practice. I think in order to create the conditions for co-production to take place, we need to build on the strengths of previous good quality engagement processes, and where communities have been involved in decision-making processes before, so they have that skills, they're informed, they have the confidence to be able to contribute. And I think we need to make sure that there are mechanisms to allow them to do that. And I think one of the things that we've picked up and I suppose supporting the network and trying to create a body of people who are interested in practice co-production is that sometimes the way that we approach what we're consulting people or engaging people about is very much from our own perspective. And it's quite often within, I think, a service delivery context that we are asking people about the delivery of those services, as opposed to what health, what issues might be affecting their health, and just keeping, I suppose, that engagement in a much more broader footing, if you like, so that they can then contribute their own kind of lived experience to a range of factors that may then be siloed into a kind of service delivery model. So I think in order to create those conditions, we need to have an open and honest dialogue and just make sure that we're not confining people too much within a consultation type process. And I think people have found a benefit where that has taken place. And I think that sits alongside, I think there's a place for consultation where, decisions can be predetermined. And I think there's a role for good quality engagement. So all of these things taken together, I think will allow people to contribute in the way that they want to contribute and where they feel that they're best able to do that.
Suzanne Martin.
Yeah, I would agree with a lot of what Susan has said. Going back to the research that we undertook, just to give you sort of a snapshot, just under 40% of respondents said that they were not as involved in decisions as they would have liked to have been about the support that they received. Around 80% were never asked what mental health services they would like in their area, and around 60% felt that they were not offered the most appropriate support at the right time within the last year, which just goes to show that certainly for people struggling with their mental health, there is an issue in terms of engaging those people around what support they receive and what their support looks like, especially in relation to primary care. In terms of how to go about that, there's obviously a lot of fantastic organisations in the third sector in particular working on co-production that have co-production models that I'm sure that the committee can look at or maybe has looked at. I interestingly heard something at a conference which really I thought was really interesting, is that co-production needs to be an ongoing partnership, which I thought was a really pertinent point, that it can't just be sort of one consultation. It needs to be an ongoing partnership with people. So I would probably say that co-production should take place on that basis.
Supplementary, Alec Cole-Hamilton.
Thank you very much, Convener. My question comes back to the old dichotomy or the disparity between mental and physical health in our society. Obviously, this is primarily directed at SAMH, but I'm welcome to hear the views of other panellists as well. And that is, we consistently hear that if you have a physical ailment, whether that's a cancer diagnosis or a broken leg or anything like that, you report it your GP and you begin a process of treatment, having everyone understanding what's wrong with you. Whereas with mental health, you often have to retell your story again and again, subject sometimes to your own re-traumatization of having to relive those events. Why are we still getting that so wrong? What needs to change?
This is where I get to speak about mental health stigma. So thank you, Alex. Yeah, mental health stigma is still a massive problem. We are having, things have improved. The mental health conversation has opened up much more, especially at a national level. We have CME, the Anti-Mental Health Stigma and Discrimination organisation, who are doing fantastic work to reduce mental health stigma and discrimination across Scotland. But there are still things that we need to do in order to get rid of stigma, mental health stigma completely from Scotland. People still find it very difficult to come forward and disclose a mental health problem to someone. I think in order to address stigma, there's a lot that plays into it. It's quite a complex issue in terms of how you address that. Looking at primary care as an example, and GP surgeries as an example, if it's about, often it's about building a trusting relationship with somebody. It's about the GP or the person that the healthcare professional the person has gone to see having the skills to have a really positive and non-stigmatizing conversation about mental health. And I think that there are also a lot of issues in terms of when you talk about people retelling their story over and over again, there are barriers to receiving support for your mental health still within Scotland. One of the biggest barriers is possibly potentially waiting times. Waiting times are quite long for psychological therapies and for CAM support, for example. We were the first country to introduce the psychological therapies waiting time, which is fantastic, but NHS boards are consistently failing to meet that target, which is problematic. And for the first time since the target was introduced, in one quarter this year, there were no NHS boards that met that psychological therapies waiting time target. So we're not really seeing an improvement in accessing, key support like psychological therapy for people. We are calling for a review to take place into why NHS boards are consistently failing to meet that target. And I think by doing something like that, we can look at what are the problems that are stopping NHS boards from meeting the target? How do we address that? And then look to make support services like psychological therapies much more accessible for people. And then that means that when they do ask for help, people like GPs feel able to refer them to a psychological therapy or potentially another treatment or support without the fear that person might be sitting on a waiting list. So there is a complex issue. Stigma comes into it, but there are other barriers that come into it as well. So yeah.
And maintaining a focus, please, on primary care in particular. Jane Cunningham.
I think that mental health problems are generally rooted in people's experiences, and I heard your question earlier about sort of medical model, social model, and so things like trauma, inequality, lack of opportunity, violence, domestic abuse are all factors that we have to consider when we look at mental health. And I think the illness, like any other approach, is not necessarily delivering for people, and sort of leads to some of the blocks and barriers that people face when they're looking for solutions. And I think, as Suzanne said, part of it is simply about being listened to and heard and having those experiences validated, as well as having these very skilled conversations actually around, you know, what we can do to help. I think one of the models that we're finding that's delivering that has been commissioned in Elgin, for example, which is a wellness centre. And it's a walk-in centre. It's in the middle of the town, it's on the high street, and somebody can just walk in and get help fast. They tell their story once, it's a gateway to other services. So, we were originally anticipated that it would be 400 people that we would support in the first year, and 1,500 people have had support. And that's one example of, and actually part of that links to, just to go back to the previous about an example of collaboration around making recovery real, which has also been fundamental, led by the Scottish Recovery Network in that area, to looking at, in collaboration, what are the needs of this community and how can we best serve. And I think that way of thinking about certainly the initial support and the first response for people, I think has value.
Thank you very much. Claire Stevens.
Across our network of third sector organisations, the single biggest issue that has been on people's agendas for the last 3 or 4 years is actually loneliness and social isolation. And that's been regardless of whether the organisations are mental health charities or charities supporting people's physical needs. So I think that the links between loneliness and social isolation and poor mental well-being, and in some cases, you know, actual mental illness and poor mental health are well documented, but also the links with physical health. So I think we've done a lot of work to help influence what became a Connected Scotland, the loneliness and social isolation strategy, and we're involved in the implementation of that. But I think it's also an example of where, going back to the earlier question about, you know, how are communities and people are involved, I think that issue has really come up from communities, and I think that's why organisations have picked up on it and are telling us that. And we did our own research into the lived experience of loneliness and social isolation last year, talking to people from a range of backgrounds, black and ethnic minority, rural communities, deprived communities, so a whole sort of wide range of people. And what was interesting in those conversations was that some people talked about primary care, and what people were saying was that they would sometimes go to their GPs really because they were lonely and socially isolated, but actually didn't know where else to go, so it was their first port of call. But actually they then recognised the GP hadn't got the time to listen to them, to sort of really listen to them and to help. So I think that's come through, and probably in some other responses that you've had to the written evidence as well, that there's and the link in terms of the question and primary care is the need for primary care to be compassionate and to have the time and the resource and the skills to be able to listen to people, because loneliness and social isolation might be at the end of, in terms of the spectrum of health and well-being, where there's time to actually prevent things escalating and perhaps become more serious mental health issues later on.
Okay, thank you very much. Those answers have stimulated some further comments, but we'll get another chance to address those in a few minutes. David Torrance.
Thank you, Convener, and good morning, panel. Is there adequate engagement to ensure that TSIs in the third sector generally are fully engaged in how services are designed and delivered, given the important role of the third sector?
Gail Anderson.
Yes,
I answer that one. I think I can only speak for my own experience in Orkney in terms of engagement with our statutory sector colleagues. And I think there is a real desire there for us to be involved. We are a member of the Integration Joint Board. I have been asked to chair the Strategic Commissioning Group there. I'm on various other partnerships to make links, and also we have a very robust third sector forum where we engage with and keep our third sector fully involved. Our role is really not ourselves to always be there, but to ensure that the third sector itself can contribute to these discussions and to influence and engage with our partners, particularly when planning services. And they also bring, importantly, they bring the knowledge and understanding of those that they work with. And they are the route into the voice of those who are perhaps not often heard when services are being delivered. So from my perspective, there's much yet that we can do as a TSI, but I think in Orkney we are beginning to do that quite effectively.
Thank you very much. Anybody else? Claire Stevens.
And I know that in Edinburgh, the third sector interface in the shape of Edinburgh Voluntary Organisations Council are very involved in all of the sort of planning structures and systems for health and social care integration. And I believe that in Edinburgh there's a primary care reference group that the third sector interface sits on. And I think that's helped the third sector interface ensure that in terms of planning and the primary care improvement plan, that the third sector is as involved as it can be. And one of the examples that EVOC gave me was that EVOC has been involved in helping train GP receptionists, for example, in a basic understanding of social prescribing. I think not in order that receptionists become social prescribers, but so that they've got a better understanding of what's happening with the rollout of community link workers.
Can I ask what planning the first sector's doing to ensure that there's a right workforce there within your sector?
A big question. Please feel free to answer for your own bit of the third sector rather than everybody. Suzanne.
In terms of sort of SAMH's workforce planning, it would very much depend on the type of service being delivered. We deliver a range of services. Some are community-based and drop-in services, and others are sort of more social care services that support people with severe and enduring mental health problems. So it would depend on the type of service being delivered as to our workforce planning for each of our services. In terms of what we find is very effective in terms of working with people with mental health problems, having a one-to-one approach for a lot of our services really increases engagement. We have a service called excuse me, My Life Dynamic in Aberdeenshire, which works with primary care and receives referrals for people who are struggling with their mental health. And that can be low levels of moderate mental health problems. And My Life Dynamic staff work with a person on an individual basis to decide what support they would like, what they think would help them, and to help them get that support and start them on that journey and support them on that journey through recovery. Our referrals to My Life Dynamic have more than doubled in the last year, and we're working with around 250 people. So I think that approach that we have in terms of that one-to-one sort of key worker with one person is really effective at keeping people engaged. But it would very much depend on the kind of service as to sort of the staff that you would have within the service.
Susan Paxton.
Yeah, I think it's probably fair to say that there is no mechanism, I suppose, for a strategic coordinated approach to workforce development for the third sector across Scotland. The extent to which that happens locally, to be honest, I'm not particularly sure that is the case. I think in any case, and certainly Claire and I have been involved in learning programmes supported by NHS Health Scotland to mobilise and raise awareness around inequalities. So our perspective on that was to ensure that that wasn't done solely for public health professionals or workforce, or for third sector for that matter. We advocated an approach where it was multidisciplinary and cross-sectoral learning programmes that were put in place there, and it was very modest and small scale. Nevertheless, what we found from participants' evaluations of being involved in that was that the understanding from each sector and across disciplines enhanced their awareness of how they might take action to address inequalities at a local level and in the course of the work that they do. So we think probably, again, fair to say that in terms of advocating for workforce development and upskilling of people to mobilise around common issues and around health and well-being, that could be done or should be done in a multidisciplinary cross-sectoral setting. I guess the issue there then becomes one of resources and how that would be resourced.
Anderson.
Thank you. Yes, I think I agree very much with my colleague here that training together helps to break down barriers. It helps each other to understand where their strengths are and where their areas of development are. And I think in the challenges of recruitment that we have in Orkney, and I believe probably across Scotland, but particularly in Orkney, it's really important that we look at our workforce in entirety so that the statutory sector and the third sector work together to identify where the strengths are, where the different skills are, and where each could support each other in a very demanding situation in terms of the difficulty of recruiting staff. So workforce development is really important about recognising the third sector as a critical part in that.
Okay, thank you very much. David, yes.
Data sharing and the barriers to it, how does that affect the first sector being part of that multidisciplinary team in primary care?
I would come back to the point that was made earlier about people with mental health problems having to retell their story. In terms of data sharing, we would like to see a situation whereby people don't have to go over the same details again and again in order to receive supports. If they have received multiple referrals or are receiving a referral, we would like that to be done in such a way that it allows somebody to engage with whoever is they're receiving support from, without them having to potentially put themselves at risk of reliving an experience or having to talk about an experience that can be quite difficult or traumatizing. So that's probably all I would have to say on that, is that we would like a situation whereby somebody doesn't have to go over the same details again and again once they've been referred to the support that they need.
Jane, comment and then Kirsty.
I think I would say that our experience on the whole has been very mixed, and I think that's quite interesting. So there are areas where we found the data sharing processes fairly straightforward in terms of implementing protocols, agreements in a way that enables information to be shared. So NHS net email accounts, people who've, I guess, taken a solution-focused approach to it. How can we make this happen? Been quite creative around that. To areas where actually it's been much more problematic. Some of the issues that were talked about earlier in relation to trust, as well as, and I think there's an anxiety around, understandably, at the moment. So. So I think there's an opportunity to share some of the learning from the good practice and the solutions that have been found in some areas with areas where there seems to be more of a struggle. And so highlighting how this can be done, I think would help, because it doesn't have to be a barrier. There are solutions to it. We just have to be creative around that and share the learning and the good practice.
I agree. I think it is a very mixed picture, but certainly a number of charities in our network have commented on how the fact that there's multiple records that aren't shared, and that this hinders sort of integrated working. And charities like Marie Curie, for example, which works closely with primary care, they've commented in their written submission about the key information summary, which is a record managed by the GP, which if Marie Curie were able to add information to that information summary, it would aid integrated and joined up care for people at the people at the end of life, for example. And British Red Cross have recently published a report called Life Beyond the Ward, which looks at what happens to people when they are discharged from hospital. So there's quite a strong emphasis on older people being discharged into what should be integrated care in the community. And they give a case study of an elderly couple where I think the man was admitted to hospital, was then discharged after a relatively short stay with a letter, a copy of a letter to his GP, as he thought, and he waited and waited and waited to hear from his GP to find out what was his care going to be next, and eventually went and made an appointment to see his GP, to find his GP hadn't received a letter direct from the hospital, and his GP didn't know he'd been in hospital, and indeed the patient was supposed to have given their copy of the letter to the GP. So this was a case study in the British Red Cross report just to illustrate how those sort of hurdles make life really difficult for patients.
Absolutely. Brian Whittle.
Just on that point, a little bugbear of mine. If the patient owned the data, and then they were able to suggest who should get access to that data, is that a solution that you would welcome?
Nods don't count. You'll have to.
That we talked about, because DBI, for example, I don't know if you're aware of the Distress Brief Intervention Programme, that for me is a good example of data sharing that exists, but to do what you're describing, I think takes it one stage further, but it means that there's a central record that the person has access to, and we talk a lot about self-management, for example, but in order to co-produce, to self-manage, to apply all these things, you also need access to the information that's held about you. And the issue about telling your story again and again, even within DBI, where we have the data sharing protocols, etc., there's still an element of going back over a story you may already have told the police, or whoever it may be. And I think speaking very personally, as a patient, a user of primary care myself, I think that it's something that, in terms of my rights as a citizen, as a person, then I think that it makes sense. And if we want people to take more responsibility, more self-responsibility, self-manage, whose information is it?
I think that in terms of accessing data, I think it's data about the patient. They should be able to access they should be able to request their medical records and see that information. I think in terms of sort of patients, patients should be able to say, I would like, if they're being referred on to a service, I would like this information to be shared with that service. There's a right to confidentiality as well. I think it probably comes down to shared decision making and the conversation with healthcare professionals working in primary care, and talking to the patient about what they would like to be shared and how that can be used to support them, and how the information might be helpful to giving them support and care and treatment. So I think shared decision making is a huge thing in primary care, and it needs to be about that conversation with the patient.
Okay, thank you very much. And I think generally the question of who owns the data, I think I saw nods all round. Would you simply like to answer the question in one word? Yes. Okay, George.
Before I go on to my own question, I'd just like to follow on from what Brian already mentioned about the sharing of data. It's the biggest issue that we're getting this is coming out is how people access, and if the individuals have control of that. I've got my office manager has multiple long-term conditions, and I've noticed that his consultants, he's got access to a database where he can see letters going back and forward to the various consultants. Don't know if it's a pilot or whatever, but it gives him empowers him to be able to make a decision of what he's going to do next when he goes and sees the consultant. He spends less time with the consultant because he sees access to that, because he's already kind of thought this through before he gets there. But one of the things we walk about with small computers in our pockets. You know, surely it's not rocket science for us to get to a stage where, you know, all the data protection stuff and everything else, you could basically just checkbox that and say who was actually getting access to your data with regards to the health service as well. Surely in the 21st century, we can get ourselves to that stage.
Sorry, in terms of, I think there's also an opportunity for involving people much more than in planning and decision making about their own, because you know there are examples now of using technology and data records for people to input almost like a health diary. So for instance, if I'm somebody who's experienced a mental health problem and I'm, you know, under the care of my GP or practitioner, whoever it, if I can almost maintain my own record and my own story, then I don't have to repeat that. I don't have to take up the first half of my appointment, for example, going back over, you know, what my experience has been in the last 2 weeks since I saw somebody or whatever. So I think that, you know, if we think about it very carefully, there are ways that it can absolutely add value for the person's experience as well as for the organisations in terms of streamlining their processes. But I think it is about whose information is it, why do we have it, and how are we going to use it? And if we're focused on that and how we can benefit the person at the end of the day and how we improve their experience, then there are absolutely opportunities, and there are some already good solutions and good ideas around this that I think are worth looking at.
Suzanne Martin.
Yeah, I would agree with Jane, and I think for us and for people with mental health problems, it comes back to retelling the story over and over again, which is very unhelpful. And I take your point about focusing on primary care, but there's an interface between primary care and secondary care that is really important here. And taking young people as an example, if a young person is really struggling with their mental health and is experiencing a mental health crisis and they go to their GP for support and they are referred to CAMHS for assessment, they then possibly receive a face-to-face assessment and have to retell the same story that they told the GP to the CAMHS worker, and potentially not to receive support if they are rejected from CAMHS, and then possibly, not all the time, signposted to maybe a community-based service, and then potentially have to retell their story again to that community-based service or that third sector service that they've been referred to. There's a problem there if that young person is being forced to retell their story again and again, and I think there are solutions, and you know, I think that the committee should certainly look at you know, technology and how that can contribute to data sharing and people not having to tell their story again and again. But that's what it comes down to, is people shouldn't be forced to go over the same details in order just to receive support for their mental health.
Thank you. George.
Yes, just to go on to my questions, hopefully you heard the questions asked in the previous session, but it was just Claire Stevens says intervention at an early stage of someone with a low-level mental health issue probably helps it from getting on to the further on. And my question would be, is mental health an issue where medical and social models of care could complement each other, you know, and make sure we can work with it in that way? I gave examples earlier on, and for a certain cohort, male, older, that would work, but not for everyone. And are there ways we can get this to join up and work together?
Who would like to? Jane Cameron.
Maybe this is an opportunity to talk about something like Making Recovery Real as an example of collaboration and finding solutions that work for people within communities. So this was a programme run by the Scottish Recovery Network, where they worked in two areas, Dundee and Moray, and brought together commissioners, providers, people who use services, families. So there was a whole representation of people in the area, and looked at what they felt were the priorities in their community, and worked together on then designing, co-producing solutions, and then that then informed the commissioning practice. And I think that in terms of many of the solutions, therefore, that came were more within sort of social aspects, addressing some of the social, the isolation that was talked about earlier, but obviously being focused on communities, not taking a one-size-fits-all approach to what those solutions would look like. I think that in terms of low-level and then health care and treatment, we know that people with mental health problems experience increased issues in relation to physical health, combination of long-term conditions, etc. So, everything has to work together with the person at the centre. But certainly for me, if we invest more in the prevention, early intervention aspect of mental and physical health, then if we spend more on the former, hopefully we spend less on the latter. We need to spend less on the latter, it seems. And hopefully these examples that are being generated will do that, because we know the pressures that people are experiencing trying to access primary care, secondary care, what have you.
Gail Anderson and then Susan.
Yes, I totally agree with that, and our communities have also raised the issue of social isolation as being a real issue for them. Some of the solutions, obviously, from third sector are befriending, and that is one-to-one befriending where that works for that person, but also increasingly group befriending and bringing people together for physical activity, for other activities that are fun and enjoyable, that fit their needs and their interests. Two other things that have happened in Orkney particularly, and for men, there is a men's shed, excuse me, which is very popular. But there's also been set up what we've called the Seafarers Gathering. Many of the men obviously have been at sea. They have a shared interest. And in looking at what their profession was, their work was, that is a single common interest. And it isn't for men particularly that you need help. It is come along and talk about what interests you with other people who understand what you were involved in when you were throughout your working life. That's also been looked at for agricultural workers, for farmers. So there are different methods of bringing people together, particularly men, perhaps focusing on their occupation or single points of interest. But that social isolation is absolutely key to that well-being strand of early intervention and prevention.
Suzanne Martin.
I'd like to make 2 points, one about community-based services and one about community link workers, and I totally agree that there are things that we can do to better link up physical health and mental health. Mental health affects physical health affects mental health. It's a circle. We need to, I think there's been improvements in recognising that, but there's a lot more work to do in recognising that. I think in terms of sort of preventing mental health problems or intervening at an early stage, I'd give an example of if somebody has, arthritis, it should be a case of if someone has arthritis and is really struggling with that arthritis, that, whatever healthcare professional they're engaging with, we would want to see that their mental health would be considered as part of the support that they're receiving for their arthritis, and that they would potentially be, if that person wanted support for their mental health, or if it was viewed as their well-being, then they would be signposted onto an appropriate service, possibly in the community. That means that we need community-based services to support people with their mental health, and it also means there needs to be a link between sort of GP surgeries, pharmacies and things where people might be receiving prescription medicines, or people might be receiving advice from their doctor in order to link them with those community services. And I think that's where the community link workers come in. And we have a community link worker service in Aberdeen that is proving really effective. And, initial findings have shown that there's potentially been a really positive impact on reducing the number of times an individual might see a GP if they're seeing a community link worker, and that evaluation will be coming out later this year, so we're happy to share that with the committee. So I think, yeah, we need to think about health in the round. That includes mental and physical health. Thinking about health in the round doesn't mean that we should stop talking about mental health. It's still mental health and also physical health. But yeah, people's mental health should be considered by healthcare professionals when they're receiving support, and they should be linked to appropriate support.
Okay, thank you very much. Claire Stevens.
I thought it was very telling that Anne Crandalls in the last session said that integration in Edinburgh was absolutely driven by the desire and the ambition to drive down social isolation and loneliness. So I think it's a very, very, very important theme. You may want to look at what NHS Ayrshire and Arran are doing as part of the 3 health and social care partnerships in Ayrshire in relation to social isolation and loneliness, because they're taking the same sort of approach. They see, tackling those sort of issues early on as a preventative means of, saving money upstream and supporting people's health and well-being and preventing issues escalating. NHS Highland has also done quite a lot of work in relation to isolation and loneliness of older people and what is happening at a community level across Highland. And Scottish Public Health Network are currently doing a mapping exercise of what NHS boards and, I suppose, as well, health and social care partnerships are doing in relation to social isolation and loneliness. So the original question was about the social model of health or the medical model of health. So I agree wholeheartedly with colleagues in this session and other sessions that the two are inextricably linked.
Can I just ask just one final question? It's interesting that we've all ended up in social isolation being a major issue. If I use an example of an individual that I sit next to the football for years, his wife died recently. He was her carer for that period. She had multiple sclerosis, then she had dementia towards the end of her life. So his whole life has worked round the love of his life effectively for the past 20 odd years. She was in a wheelchair towards the end, and they didn't stop them doing anything, they carried on. Now I asked that classic stupid question that people ask at that time when I met him: how are you doing? I hadn't seen him since the funeral, and asked that stupid question, which I should have known better: how are you doing? And he honestly, which is very unusual for the male of a certain age as well, answered, says, "I'm not looking forward to the winter, George, because the long nights in my own and not being able to go out." Now, the advantage in that scenario is he's aware of the challenges coming up. But what about the other people that we've got out there? How do we actually get all these services to join up and make sure we get these people, where they could end up just slipping through the net because they're sitting in the house looking at 4 walls, and then their mental health and their physical health gets to the stage where they're not going out, they're not seeing anyone, and their life just starts to change from then on? How do we make sure they don't fall through that net?
Jane Cumming.
Well, I think that for me, one of the things around what you're describing is about the use of data, the use of information, the use of... So we know essentially the life changes, the transition things in people's lives. We know the factors that influence people's mental health. And it's about then using that information to plan responses that we know are then going to make a difference. So exactly, for example, again, going back to Elgin, we do work in other areas.
Don't worry, my wife's family's from
Okay.
Elgin, so talk about it as much as you like.
It's worth a visit if you haven't been.
I'm never away for the point.
Yeah, okay. So, recognise. So when we opened the wellness centre and we recognised, that yes, it was effect people were coming, but there was a gap in terms of men, of a certain age. Mm-hmm. Coming through the door, and so we just began a social media campaign around just called Mention It, to try and address that and reach out and say it's okay to talk about your mental health, and if you want to come and talk, this is somewhere that you can come. Now that's a small example, but it's about pulling together what we know, the information that we have, the things that we know that affect people's mental health, and designing what we do around it, and making it okay to have those conversations. But I guess the other thing around that is about the capacity and the awareness of the community around about, so that when somebody does open up and is open and honest, that they can be confident and trust in the response that we have, that they will have from that. And Suzanne talked about stigma before. But there's a lot of self-stigma happens too. People are anxious about expressing, and generally people are kind.
I have a supplementary from Emma Harper, which I think may be relevant to this question as well. So,
Yes, absolutely. You mentioned stigma, and Suzanne, you mentioned destigmatising. So there are programmes already out there. I love the fact you've got one called Mention It. I know the young farmers started the Are You OK, EWE, and so there's other programmes about it's okay not to be okay. So the fact that we are making progress in destigmatising means that more people are opening up. So that means that more people will then seek services. And I agree with George, Adam, that if we can get people really early on and have our community link workers direct them to social prescribing type opportunities to tackle isolation, especially in rural areas, that would be a way to go. So the destigmatising aspect will contribute to more people wanting to access care. Is that what we're seeing?
Susan Martin.
Absolutely. As we continue to reduce stigma, more and more people will come forward for support, and therefore we need to be ensuring that we're providing services to support those people. In terms of sort of early intervention and prevention, and the example that you gave, George, I think, as Jane has talked about, there's an element of whoever has been engaging with your friend and his wife, whatever support they were receiving from whatever healthcare professionals, we would like to see all of healthcare and healthcare professionals considering mental health when it comes to all health-related issues.
Suzanne, that's my concern about the scenario. Is effectively his wife's dead. Yeah. It was her long-term conditions that they were dealing with, and my concern is they're just. He's left there in the house himself, locks the door, puts the telly on at night, and that's it.
I mean, I can't comment in detail on the specific situation, but I think, if he, as an individual, was known to the healthcare professionals working with his wife, that, linking him into sport, knowing that he's just lost his wife, that would be something that we would like to see being done, is that, the mental health of people is being considered when they're engaging as a family unit, as a couple, as an individual, and that they are being linked to support when something happens in their life, or when they're experiencing a physical health problem, or they've experienced a bereavement or a traumatic event that they've maybe told their doctor about in conversation, and that their mental health is considered, as part of the package. And I think, there are improvements certainly to be made on that basis, but it's also a case of, as Jane said, about raising awareness in terms of having services based in communities that are, really easily accessible, that people know about. We've got a really good service in Fife, in Kirkcaldy, called Sam's Cafe, which is a cafe based in Kirkcaldy that people can just walk into and talk about whatever it doesn't even have to be about their mental health, but it's designed as a space for people to talk safely about their mental health if they want to do that. And, we need more of those kind of community-based services that people can just walk into to talk about their mental health, and we need people to know about them as well. But it's also about, healthcare professionals considering mental health sort of in every aspect of the care that somebody receives, and maybe not just the individual's care, but their partner, how that is impacting them as a carer. We have a service in Dundee that is a care support service that supports people who are caring for others. So, we would like to see more services like that, where everyone's mental health is considered and they're linked into the appropriate support when they need it, depending on their individual circumstances.
Okay, thank you. Claire Stevens.
I just wanted to raise a point about community link workers. We've heard a lot about community link workers this morning, and it's very encouraging that 250 community link workers are being rolled out. And I believe, Emma Harper, you said you thought there were probably 56 of those new community link workers had been created, which is my understanding as well. But we don't actually know where they all are, and it would and it's almost throwing a question back at yourselves, I think it would be an interesting question for the committee to ask, where have the new community link worker posts been created? Are they in urban areas? Are they in rural areas? Have they actually gone to the areas with the highest level of health inequalities, which is where, you know, the funding was supposed to be directed? What sort of impact are they having? And also, what impact are they having on the capacity of third and community sector? Because there's a sort of quid pro quo. There needs to be a balance here. You cannot endlessly refer or signpost or support people into services or into activities if actually they're not there and being invested into equally. And again, just using an Edinburgh example, I know the Health and Social Care Partnership has been quite far-sighted in terms of both creating, as I understand, sort of nearly 20 additional community link workers, but also looking at investing in third sector activities which people can then be supported into. But I'm not at all sure that that's the case throughout Scotland, and certainly we're getting, albeit anecdotal, feedback that some particularly smaller voluntary organisations and community organisations are starting to feel the strain in terms of increased referrals, but without any compensating resource to help them deal with that.
Thank you very much. It's a very important point, and it is one we explored to a degree with the previous panel. It's certainly something we will follow up. Brian Whittle.
Thank you, Kavina. What we're looking at here is primary care and the role of the third sector within primary care. And given the ability of the third sector to carry and shoulder quite a bit of the load, things specifically around mental health, specifically around drug and alcohol services, which are intrinsically linked, I think with mental health. Where do you think funding available lies just now? Do you think the funding is proportionate and adequate to the services that can be delivered?
Suzanne Martin.
I can comment on mental health funding specifically. You will have seen in our submission that we have highlighted that mental health spending is quite difficult to track in Scotland, but we do know that for the first time the Scottish Government is spending over £1 billion on mental health, which we welcome. That is around 8% of the overall health budgets, which in comparison to England is slightly lower. They're spending just over 10% on mental health. It's difficult for us to know how much of that mental health expenditure is going into primary care specifically, how much of it is specialist care in sort of secondary services. It is very difficult for us to track. The Lancet Commission on Global Mental Health has recommended that high-income countries spend 10% of their overall health budget on mental health, and that there should be a shift towards funding more community-based services, and that funding should be shifted from hospitals into those community-based services. So we have, we would support those recommendations in terms of, the funding maybe being shifted towards more community-based services. I think there does, as has already been noted by Claire, when you have programmes like community link worker programmes, the number of referrals to the third sector increases, and we need to make sure that the third sector is able to meet that demand and community-based services are able to meet that demand. So yeah, I think in terms of mental health, it's difficult for us to track and know where funding is going and how much is going into primary care and how much of the primary care spend is being spent on mental health. But certainly from the figures we have, it would indicate that we are slightly below that 10%.
Anyone else on those funding issues? Susan and then Gail.
Yeah, I just wanted to say a little bit about I think sometimes the pressures that are on third sector organisations, I think what they're particularly adept at doing is bringing in multiple different sources of funding that can contribute towards, the improvement of health and well-being that then has a knock-on effect to our statutory partners and delivery of services through that. We're seeing some, I suppose, positive developments. I think typically within the sector people will say, that they're continually on short-term funding cycles, and that doesn't lend itself well to the sustainability of services and the support that's provided to communities. And where we've seen extended funding cycles, for example, 3 years, and I'm thinking particularly of the Inequalities Fund through Edinburgh Health and Social Care Partnership, what that's resulted in is, in creating that kind of funding cycle, is opened up, I suppose, the fund to a whole range of newer applications. And what that inadvertently did then is it put in jeopardy some of the longer standing organisations who would typically be in receipt of those types of funds. And the other added element, even though we welcomed the introduction of kind of longer term funding cycles, is that it quite often does come at increasing competition, and it is wrapping up existing funds with less money. And I suppose that conjures up, not specific to our sector. I think more and more people are saying they're having to do more with less. But it is putting a particular strain on things. It's perhaps useful to have a better understanding of just how third sector organisation is contributing in terms of the money that they are bringing in to particular communities or areas, and how that then compares against kind of medical services and healthcare provision.
Gail Anderson.
I think my colleague has largely made the points that I was going to make about that resourcing issue for third sector.
Just, one of the things that you mentioned there was competition for funding. I think, again, we're looking at the primary care budget and the proportion of which that primary care budget is being allocated to the third sector, and what's happening, you know, the resources coming back the way, if you like, the way that's being utilised. I think my question would be, one, the way which we are funding the third sector through primary care, does that have to change to try and eliminate this kind of competition? And is the third sector aligning itself in a way that makes it easier to fund? And specifically, I mean, I look at the way Sam H is now working with Job Scotland. Who would have thought? You've made my conversations in here so much easier in the chamber, let me tell you. But is the third sector aligning its services in a way that makes funding of the third sector through that primary care interface and IJBs easier?
Who would like to answer that?
That's a good question, isn't it?
Gail Anderson again.
I think that will largely depend on how involved they are at the planning stage, about bringing their expertise, their understanding of the gaps and the needs within the population that they're serving into discussions and to plan local services. I think in that way then they will definitely align their services with what is needed in that area. So I think their involvement in planning is really crucial.
Thank you very much. Suzanne Martin.
Yeah, I think as an organisation working in 60 communities across Scotland, we have very good relationships with you know, the health and social care partnerships that we work with, that we deliver services for. So I would say that our relationships are good, and we're having really positive conversations with the health and social care partnerships that we work for. It's already been mentioned that an annual funding cycle makes life difficult for some for most third sector organisations, especially small third sector organisations. So that is problematic. I think I would agree with what Gail has said around talking to the third sector, and the third sector talking to public bodies to make sure that the services are being designed in line with what the third sector is best at and what it can provide, and also talking to individuals about what they would like to see. And I think, in terms of the way we align ourselves as an organisation, we have very good relationships with public bodies and also with other national organisations in terms of delivering services at a national level or at a local level. But there's definitely improvements to be made. There's probably a lot that we could say, and it could go on for another hour about how that could be done.
Very much. Unfortunately, we don't have the time to go on for any longer, but thank you all very much for what's been an excellent evidence session. I'm conscious that by the nature of it, we have touched on quite a lot of issues which we've not had the opportunity perhaps to fully explore. So if there are other points you feel that you would have liked to make had we the time, then please feel free to provide those to us. And thank you all very much once again. We will again suspend briefly, resume in public session in just a moment. The next item on the agenda is consideration of EU exit subordinate legislation. We start at agenda item 2 with the Food Information Labelling and Standards Regulations 2019. These have been given the low categorisation by the Scottish Government on the basis that the instruments make mainly technical amendments in order to fix deficiencies in domestic law. That's also the view of both SPICE and the Office of the Solicitor of the Scottish Parliament. And the Delegated Powers and Law Reform Committee on the 24th of September agreed that the instruments should be considered under the negative procedure and with the low categorisation. First of all, can we take a decision on whether the categorisation provided by the Scottish Government in this case is correct? Are we all agreed that that is the case? That is agreed. Thank you very much. We then move on to agenda item 3, which is two negative instruments, one of which we've just touched on and we'll come back to. The other of which is the National Health Service Serious Shortage Protocols Miscellaneous Amendment Regulations 2019, intended to allow pharmacists within a community pharmacy to supply an alternative quantity, an alternative pharmaceutical form, strength or therapeutic equivalent without going back to the prescriber. Again, the DPLRC at its meeting on the 24th of September determined that it did not need to draw the attention of the Parliament to this instrument on any grounds within its remit. Can I invite comments from members?
Yes.
Emma Harper.
Thank you, Convener. I just have an interest in this because I attended an event about medications and the bioequivalence of generic or different companies providing a medicine that's supposed to be essentially the same. So I'm interested to find out about whether issues of bioequivalence has been explored, because there's different definitions by the World Health Organization and in Australia with the Therapeutic, the Goods Administration, the TGI or the TGA, and also in Europe and the USA. So the FDA have a different definition of bioequivalence as well. So, and I understand that pharmacists might be the best placed to decide whether a drug does have bioequivalence standards, but there's many patients, I understand, that GPs will take a long time to support somebody's medicine with anti-epileptic meds or warfarin or levothyroxine. So I think this is an issue that isn't just cut and dried.
I take the point that is a substantial point in what you say. Colleagues, we need to report on this matter by the 6th of November. So if colleagues were so minded, we could seek clarification from the Scottish Government at this stage and then consider the matter again at our next meeting or the meeting thereafter. Is that agreed? Emma, you happy with that approach?
Yes, I am, thanks.
Thank you very much. The other item under this agenda is the Food Information Labelling and Standards Regulations 2019, which we have already discussed and is now subject to the negative procedures. Are there any comments from members on this instrument? If there are not, are members agreed to make no recommendations regarding this instrument? That's agreed. Thank you very much. Agenda item 4 is again under the European Union Withdrawal Act, is consideration of 2 notifications from the Scottish Government on its intent to consent to UK ministers making regulations on its behalf in relation to 2 instruments: the recognition of professional qualifications, EFTA States Miscellaneous Amendments, EU Exit Regulations 2019, and the recognition of professional qualifications, Miscellaneous Provisions, EU Exit Regulations 2019. These both relate to regulations made on the 19th of February to make amendments to existing legislation to ensure that a system of recognition of qualifications will continue to operate effectively in the event that the UK leaves the European Union without a deal. These are UK-wide provisions, but obviously apply to regulated professions which deliver in devolved areas of policy such as health and many others. The proposal will ensure that these current recognition arrangements are maintained and remain in place, whatever should transpire in relation to Brexit. The first notification is the recognition of professional qualifications EFTA States Amendments Regulations, which relate to the rights of EEA EFTA nationals and Swiss nationals and the recognition of their qualifications in the event of a no-deal Brexit. Do members have any comments on this instrument? It is a negative instrument. If there are no comments, are members therefore agreed to make no recommendations in relation to this instrument? Thank you very much. And the second notification is the recognition of professional qualifications, Miscellaneous Provisions Regulations 2019, also making a further technical provision to give full effect to underlying policy of the 2019 regulations as previously agreed by this committee. Are there any comments from members on this instrument? If there are no comments, is the committee agreed to make no recommendations? That's agreed. Thank you very much. We will now move into private session for the final item on the agenda.